So, hello again. My second topic is about critical leak ischemia. Endovascular treatment is the first treatment to be proposed. Endovascular treatment in critical limb ischemia and below-the-knee lesions made great progress within the last years. A few years ago, we had quite wrong ideas about this treatment of below-the-knee lesions. Main opinion was that treatment is just possible in short lesions. Interventions are quite dangerous because manipulations in the small vessels can cause perforations, bleedings, dissections easily, and thus compartment syndrome and amputations. And interventions may destroy distal landing zones for pedal bypasses. Beyond that, as recently as 5 years ago, we had just materials suitable for big pelvic and fempop vessels, but no low-profile balloons, for example, for the small arteries below the knees. That's why the recommendations of 2000 say that just short singular stenosis are an option for PTA. Most below-the-knee lesions have not been treated endovascular. Okay. But this was an example of a short lesion. What about long BTK occlusions? Is endovascular treatment safe and feasible there? In the example on this slide, you can see a long occlusion of the posterior tibial artery. After successful passage with an O14 wire, we treated the lesion by balloon angioplasty, and finally we had a good result in a well-perfused posterior tibial artery. So, as you can imagine, by this example, it might very well be possible to treat long and difficult below-the-knee occlusions. After realizing that fact, endovascular treatment has become more usual within the last couple of years. As you can see on this image of Professor Baumgarten of Switzerland, she documented the rate of bypass surgery versus PTA in below-the-knee arteries, and you may notice that balloon angioplasty has been used much more often in the last period of years compared to the years before. Further on, a randomized trial, the BASIL trial published in Lancet 2005, showed non-inferiority of endovascular treatment compared to bypass surgery in patients with severe critical limb ischemia, despite the fact that endovascular treatment in this trial was just performed by conventional ballooning, no drug coating, no drug-eluting stents, no other systems. Problem, however, is the high rate of restenosis or reocclusions in these patients, rates of more than 50% already after 3 months. The longer the lesions were, the higher the rate of restenosis seemed to be. But luckily, there seems to be a distinct discrepancy between restenosis rate and clinical outcome. The short period of patency was apparently sufficient for wound healing and a much better limb salvage rate in the treated patients with critical limb ischemia. But as you can notice in this example, normal wound healing does take its time, in this case more than 3 months. In case of repeated reocclusions, further and ongoing clinical improvements can just be acquired by repeated interventions, and on that again and again with the risk of new complications. Thus, to secure limb salvage for a longer period of time with as low complications as possible, it was necessary to find strategies for a better primary patency and lower rates of target lesion revascularization. So what was to do? The way out came from the cardiologists, who are often a few years ahead of us. Cardiologists started to use drug-eluting stents successfully for treatment of coronary arteries, and it was also successfully below the knees. Drug-eluting stents have been proved to have a substantial and significant better primary patency than conventional balloons, as you can hear on the slide. The difference of 85 to 54%. Beyond that, the results of the Yukon study demonstrate that also the clinical outcome becomes better by using drug-eluting stents. Patients with critical limb ischemia had to undergo target vessel revascularization and major amputation less frequently during the follow-up period when treated by drug-eluting stents. The outcome with respect to myocardial infarction and death was improved as well. Problem, however, was that these coronary stents usable for the small vessels below the knees are just available in short sizes. Therefore, a sufficient treatment is just possible for short lesions like the occlusion, or like this occlusion of the tibioperitoneal trunk. But much more frequent below the knees are often long lesions like that one. Conventional ballooning, as it was performed in this case in the anterior tibial artery and the peroneal artery, causes high restenosis rates after a few weeks and maybe the need of early re-interventions. One possibility then is to perform spot stenting with drug-eluting stents after ballooning the whole lesions at the localization of maybe a residual stenosis. The problem then can be, if the treated lesion is much longer than the stented is, that restenosis will occur proximal and distal to the stent. Therefore, we think drug-eluting stents do only make sense if full lesion coverage is performed. Much more promising for long lesions below the knee seemed to be drug-eluting balloons, which are available in length up to 200 millimeters, so also for long lesions available. If you remember again the data of conventional balloons, you notice a restenosis rate of almost 70%, 3 months, already 3 months after re-intervention of the intervention. To evaluate the effect of drug-eluting balloons and to compare it with conventional ballooning, we started a prospective real-world registry in our department, where we included more than 100 patients with long below-the-knee lesions for treatment with drug-eluting balloons. Our patients had a lesion with a mean length of about 170 millimeters. More than 80% of them suffered from critical limb ischemia. Clinical follow-up was performed at 3, 6, and 12 months. At 3 months, additionally, angiographic follow-up. Here an example of a longer occlusion of the anterior tibial artery in real world. Not every occlusion can be treated very easily. In this case, we performed a recanalization from a pedal access because it was not possible from antegrade. The wire did not pass the lesion and went always in the small collateral at the proximal beginning of the occlusion, which you can see on the first figure in the middle part, right. There's a small collateral and the wire always went in that way. But also from retrograde it did not work initially, so we performed double balloon technique where we approximated 2 balloons, one from antegrade, one from retrograde, inflated and tried to penetrate the dissected membrane to pass the wire then from retrograde. After ballooning by a paclitaxel eluting balloon, we had a nice final result with a well-perfused anterior tibial artery, and 3 months later the artery is still patent and well perfused the whole length down to the foot level. Even very distal occlusions can be treated successfully and ongoing by drug-eluting balloons, like in this case of a distal occlusion of the anterior tibial artery. The foot arteries are still well perfused at 28 months of follow-up. But not only the results of singular patients were encouraging. Also the overall data of our registry showed a much better restenosis rate. Using drug-coated balloons results in a 60% reduction of restenosis compared to conventional balloons. Rate of re-interventions improved from 50 to 17% by using a drug-eluting balloon. This data are confirmed by the first randomized trial on this topic. Listro compared the drug-eluting impact amphibian versus PTA with conventional ballooning in long below-the-knee lesions and could demonstrate a much lower restenosis rate and reocclusion rate by using drug-eluting balloons. There aren't so much data about this topic so far, but maybe 1 or 2 further studies will be published this year yet. What we have so far, the data about restenosis rates and the rate of target lesion revascularization after using conventional balloons. Either restenosis rate and target lesion revascularization are quite high and increase according to the length of the occlusions. Longest lesions were included by Schmidt with mean lesion length of about 18 centimeters. Restenosis rate and need of target lesion revascularization were highest in those patients already at 3 years after interventions. 3 months, after intervention. Data after using drug-eluting balloons are much more encouraging so far. Restenosis rate and need of target lesion revascularization is much lower, even in quite long lesions up to 17 centimeters. But nevertheless, there are still randomized data missing for drug-eluting balloons in long below-the-knee lesions of patients with critical limb ischemia. And beyond that, we have no data comparing drug-eluting stents and balloons in these lesions, which would be a problem anyway. On the one hand, these stents have limited applicability. They are just available in few sizes. On the other hand, nobody would like to have the whole leg plastered with metal. And so to conclude, despite of all the primary concerns of some interventionists and surgeons, PTA and stenting is a safe procedure in critical limb ischemia and below the knee lesions, but show high restenosis rates. The improvement the invention of drug-eluting stents and balloons show much better results in studies compared to non-coated balloons and stent with respect to target lesion revascularization and restenosis rate, but also with respect to clinical improvement. And that should be the aim in treating critical limb ischemia, to improve wound healing and limb salvage rate. So these positive results have to be considered for the next guideline and things, I think. Thank you.
Merci, Dr. Friedenberger. Nous allons arrêter pour 10 minutes.